All right, now I would like to introduce Dr. Sabrina Bram and to lead our panel on driving equity in digital health for children and families. So the panel can please come on up. Thank you.
All right, so we're going to be talking about closing the gap in health equity in pediatric digital health, which I think we had a really nice opening to with Dr. Inaka. I'm Sabrina Bram. I'm a community pediatrician. I'm also the founder of a pediatric digital health company, Wellio.health, and I'm sitting here with my colleagues from the Pediatric Digital Health Task Force at Stanford. And we were brought together in 2020 because we recognized that there was a need for leadership in the advancement of digital health tools for child health, but specifically because of the dynamic that almost half of American children are covered by Medicaid. There is a need for equitable advancement of these technologies. And so our work together has included scholarly publications, thought leadership, and industry collaborations. Our most recent collaboration was with the Digital Medicine Society. We collaborated on the publication of the Digital Medicine Pediatric Playbook. So for any innovators in here, it's worth checking out. It's a very robust guideline for anyone who's looking to innovate in the pediatric space. So I will let my colleagues introduce themselves. Why don't we start with you, David, and then we'll get started. Advance.
Well, good afternoon. I'm David Bergman. I'm a general pediatrician at heart. My clinical interest has been children with medical complexity, and I've labored over 10 years in developing a digital health tool for well childcare.
I'm Lindsay Stevens. I'm a clinical professor of pediatrics and clinical informatics here at Stanford. I have an operational role at the Children's Hospital and also practice clinically, and I'm the co-chair of our Pediatric Digital Health Task Force.
Hi, everybody. I'm Naimisha Chilukuri. I am a general pediatrician at heart as well, and a clinical informaticist here at Stanford Children's. My interest is in using clinical informatics to improve access to equitable care for children in underserved communities.
Hi, everyone. Also a general pediatrician and clinical informatician. My name is Chetan Sarabu. I am primarily now based in New York at Cornell Tech as a director of clinical innovation, and have continued to remain connected to Stanford through the Pediatric Digital Health Task Force. And I've really been drawn to the importance of involving children in their care when it comes to information. And so as we think about innovations in this space that we'll be getting into, particularly motivated by how we think about the unique aspects of pediatric care.
Thank you. So we'll start with a general discussion. There should be papers on your table that have a QR code for questions, so we're going to try to leave time at the end for Q&A. Please jump in. So why don't we start with you, Naimisha? So we are talking about closing the gap in health equity for child health. Help us understand what that gap is and how we can think about starting to evaluate that.
Yeah, absolutely. Thank you, Sabrina. Firstly, thank you so much for having us here. I think we've talked a lot about several gaps today, and I think the big gap we want to talk about is the fact that children continue to be a big blind spot when it comes to both digital health innovation, but also digital health spending. Children comprise 23% of the US population now, but only 9% of the spending. And I think with the rise of both digital tools and AI, I think as we talked about, this gap continues to widen at all stages of that development life cycle. So in terms of starting with the need to focus on pediatrics, but also the design stage, the development stage, the implementation, and then testing. And I think beautifully, there was a panel earlier that talked about the gap when it comes to FDA authorized AI and ML enabled tools, with only 17% really being for pediatrics. We've talked about all this today, but I think to highlight, I think children are specifically a very unique population. in that they represent a lot of diversity. Like you mentioned, 50% of children in the United States are on Medicaid or CHIP as their primary health insurance. But beyond that, I think if you go to the next slide, Sabrina, what you're going to see is this distribution of where children are relative to where pediatricians are not necessarily overlapping. And what you'll see, and there's several publications around this, that around 40% of children are in counties that do not have access to a pediatrician. And that's represented in red. And each of these counties are different sizes, of course. But I think there's several ways in which children are experiencing disparities. Now, bringing that back to digital health tools, not only do we have a gap in the lack of focus in building digital tools for a pediatric population, but also when they're developed, they're often missing key design elements that we see are necessary to be effective pediatric tools. Are they reimbursed effectively with Medicaid to make sure that they're equitably accessible for everybody? Are they designed with the model that, this is including caregivers, and so on and so forth. And I know we'll get into that a little bit in our panel. The biggest example of this is one that we're all familiar with, which is the patient portal. It's probably one of the most widely used digital tool from healthcare settings, but it was originally designed for the adult patient to be able to access the adult medical record. And so it was not designed originally for the parent or guardian trying to access the child's medical record or the adolescent trying to access their own confidential and sensitive content independent of their parents. And so to close that together, gap number one, we need to focus more on kids when it comes to digital innovation. And number two, when we do build tools that apply to children, we have to include some of the important design elements that I mentioned.
Thank you so much. So I'm going to hone in on the first point that you made and ask Lindsay. So people say kids are basically healthy. Why do we need to be thinking about pediatrics, and why pediatric digital health specifically?
Yeah, well, the mantra of the pediatrician is that children are not just small adults. They have different physiology, they go through different developmental milestones, and they have different levels of autonomy as they progress from childhood through adolescence and into adulthood. If we really think of the child as the ultimate lever on longevity, which is a hot topic in healthcare these days, if we are addressing, most kids are healthy, but many aren't. And even if they are healthy, are we building good habits for later in life? And if we focus on both the prevention and the early management of chronic disease, we can have a healthier population more broadly. And so it's really important to kind of think about these things in design, like Naimisha mentioned. One of the things that our group has really been focusing on is the role of the caregiver in a child's life. Children have and may have many different caregivers, and they may change at various points in their life. Most often it's the parents, but there may be another guardian. They may be in foster care. There may be a school nurse or an ancillary healthcare worker or therapist that's working with them in addition to the health team. And so if you think of the family as the ultimate healthcare delivery system, we really have an opportunity to design tools that help that be more effective. But tools traditionally haven't been designed with caregivers in mind. I'll give you an example. So Ndidi was talking about diabetes. Let's say we have a 12-year-old with diabetes. They have a continuous glucose monitor. They're about to turn 13. They don't have a smartphone yet, but they're going to get it for their birthday. But their continuous glucose monitor goes to their mom's phone, to an app there, and her mom has a profile. And when they get their phone, does that mean that they automatically get access to the continuous glucose monitor and take it over? Well, probably not. But how do we build autonomy? How do we get that teenager ready to go off into adulthood and manage their diabetes more successfully? If the app itself is not designed to have more than one role, who gets to own it? And who manages the health? And what if that child lives in two different households and both parents need to be able to access and manage and understand the child's diabetes and medication management and communicate with their healthcare team? So, how can we design tools that have these flexible caregiver roles is really important. And it's not just children that have caregivers. You think about the elderly population, their children are now becoming their caregivers, and they have various needs to access different information, varying levels of access for their parents and trying to help. So can we design tools if we think through the caregiver role? It's really an equity issue. If we can design these tools that are available to caregivers of all types, those that don't speak English as their primary language, and we really just need to reevaluate kind of the change of the return on investment. It may not be in the traditional timeline that venture capital and others have talked about, and I know some of my colleagues are going to go into this in more detail, so I won't go into it right now. But thinking through, if we can help build healthy children and give them the tools to progress into adulthood, understanding and managing their health, then we're going to have a healthier population.
Great, thank you. So we've heard from Naimisha about the gaps that exist, and Lindsay helped us understand why it's important to be thinking about this. David, can you help us understand why is this so hard?
Thanks, Sabrina. This is indeed a daunting task. And so the next question is, why has it been so hard? We've actually, as a task force, talked to a number of digital health tool developers, and a couple of things have come to light. One, that there is an interest in children, and even a sensitivity to include children from underserved populations. Two, it's really, really hard to create a viable business plan that can address the needs of kids. I know there's a lot of reasons for that, and we've touched on them in that we have kids at different developmental ages, we have family members involved, just not the kids themselves. But I want to focus on who's going to pay for digital health tool development in kids, because this has really been a difficult problem for a lot of developers. So the 800-pound gorilla in the room here is actually Medicaid, or in California we call it Medi-Cal. As Sabrina said, over 50% of kids in California are covered by Medi-Cal or CHIP. So if you're interested in addressing the needs of kids, particularly underserved kids, you better be interested in Medicaid. But this isn't necessarily an easy proposition. So why is this? One, Medicaid is what they call a beneficiary plan. In other words, if there's not a defined benefit, you don't get paid. And one of the problems with Medicaid is that there's not a lot of defined benefits for engagement with digital health tools. And I know we're working in this area, but this is kind of a wall we come up against in terms of getting reimbursed on a fee-for-service. The second issue is Medicaid is highly fragmented, which really makes it difficult to consider effective and rapid scale-up and spread of your innovation. As you know, Medicaid's funded by both the states and the federal government, which leads to each state having their own unique system with their own benefit structure and their own set of regulations. If this wasn't bad enough, within each state, there's often 5 or more managed care organizations who are tasked with delivering care to a defined population. Frequently, if you're a developer and you want to work with a healthcare delivery system, you're working with a managed care organization. The problem is, just because you've worked well with one managed care organization, that doesn't necessarily translate into working well with another managed care organization. All of this really makes it a daunting task to consider, again, how you can scale up and spread any product that you should design. However, I don't want to throw a wet blanket over all this. I do think that there are some positive steps we can take with Medicaid and with other payers. And I believe we'll get a chance to touch on that later.
Thanks, David. Chetan, so our major model for financing digital health is venture capital, and it hasn't really led to a lot of pediatric innovation. I'm wondering if you can help us understand what changes are necessary for us to advance pediatric innovation, and what are the trends that you're seeing?
Yeah, thank you, and really great to be part of this discussion with all of you today. I think building on what David had just said and what Sabrina brought up, we know a huge percentage of care for pediatrics is paid for by Medicaid, paid for by the government, but we also have this world in which there's a lot of innovation in technology and healthcare technology driven by venture capital investment. ultimately there's investment that comes from public sources and from private sources, and we've gone through different political environments in which public funding has been greater and lesser. And I think we've also seen, kind of thinking about some of the successes of public funding and driving innovation, part of the 21st Century Cures Act, passed in 2016 originally, did actually lead to support for innovations in pediatric medication and medical devices that were not normally funded by industry because we didn't have those returns. We haven't seen the same thing in digital health yet. But I think moving to the venture capital community, I think overall venture capital is a huge source of funding, and being in Silicon Valley, it's really on the minds of everyone who is here. Obviously, it's not the only source of funding, but it really does drive a lot of development of technology in healthcare. But the core challenge is the time scale for return on investment. For most venture capital firms, the time scale of return on investment for pediatric care being decades potentially is just too long to justify their level of investment. And so there's opportunities that get looked at in shorter timescales, but as a whole, for what we're trying to shift in pediatric care, that's been one of the challenges. But I think we're starting to see a little bit of a shift emerging, because I think the other thing is not just looking at pediatrics, but if we look at the overall model of venture capital investment in digital health, while billions of dollars, even tens of billions or hundreds of billions of dollars have gone in over the last really decade and a half from 2010, 2011, when a lot of VC money was going into digital health, the overall system of healthcare hasn't really shifted that much. We have new apps, we have wearables, but the underlying, all of the investment has only really shifted things a little bit around the edges. And so even more broadly than in pediatrics, the venture capital community at large is starting to question how investments should work. And so I think that's a bright spot. We're starting to see changing models. For example, there's new VC firms that are starting that have more clinician representation, and that is changing the nature of the questions of what types of solutions are being explored and funded. Starting to see early signs. There are some newer VC firms that focus exclusively on pediatrics. It's still very early days, but I think we're starting to see a shift in that VC community. So I think that's one of the shifts that's starting to happen. I think another shift that we're seeing in terms of opportunities for investment in pediatric digital health technologies, we're seeing companies that normally target the employer population, so companies that create digital health solutions that can help with chronic disease for adults, typically working adults between 26 to 65 who might be getting healthcare through their employer. Many of these companies are starting to see how they can offer their solution to the children and dependents of employees. And so it's an avenue that's expanding access. Obviously, it's still leaving out a lot of children and families who are on Medicaid. But I think in the overall scheme of things, it's just an indication of some level of change and area of shift that's happening. And I think the third point of the shift in funding, obviously the big topic of discussion of every healthcare conference right now is AI. And we've heard a lot about the unique considerations around AI in pediatric care. But because AI has the potential to so fundamentally shift every aspect of healthcare, it is this moment of a great deal of transformation that's happening, and a real opportunity for everyone in this room, everyone who really cares about children, to think in a much bolder way of how we start to shift this system that we've been in.
Thank you. So you talked a little bit about funding from VC and business models that go through employers. I thought maybe we could focus a little bit on Medicaid and talk about bright spots in that space. So given that we know Medicaid is the single largest payer for children, and that it's so fragmented and difficult to work with, I'm wondering if, and I'll open this up to the whole panel, I'm wondering if we can focus a little bit on examples of collaboration or public-private collaboration that can give us hope and maybe models for the future.
I can kick this off. I think there's a lot of positive steps we can take in working with Medicaid. Probably the first one is you need to sit down at the table with them. Medicaid really wants to be partners. When you talk both at the state level and the MCO level, there's a lot of interest in digital health tool development and a strong desire to engage and to partner. There's a couple examples, particularly in Michigan and in Wisconsin, where the state Medicaid agencies have sat down with children's hospitals and large healthcare organizations and come up with creative financing mechanisms to really stimulate innovation in their healthcare space. And now we're beginning to see, at least in California, state health departments beginning to let RFPs for digital health tool development and for telehealth, particularly telemental health. And so hopefully we'll begin to see more of this in the future.
I think that, and to piggyback on what David was mentioning, I think the Cal Hope Initiative is a really interesting one if people have looked at that. I think they've partnered with 2 companies, both Brightline and Soluna. I don't think I can speak more than what David had mentioned, but I think the biggest thing, what's interesting is the models where you have the state setting the needs and then industry partners gathering around that need. And I think that's an interesting model that seems to facilitate good partnerships.
Thank you. It makes me think of what Dr. Anaka had said about designing not for what's easy, but for what's needed. And so hopefully we'll see more of these innovations where there's an RFP that comes out of a Medicaid organization. So now looking at the pediatric market more generally, are there any blue sky opportunities, any areas of unmet need that any of you want to highlight?
Well, I think traditionally there's been a lot of focus on the bigger problems that are impacting children, which I think is great, obesity, diabetes, asthma, and mental health. And we've seen a fair number of apps and tools in those spaces. But I do think that there's a real opportunity for this transition of care when children are graduating out of the pediatric space and into adulthood, and really helping them understand and manage their disease. And it may not be that we need to create a tool for every specific rare disease, but there are all of these other issues that children are dealing with, and they may be having a bunch of care coordination needs. And so how can we have tools that can help with that coordination and can help them really own and manage their care? Not all patients are going to be able to use the apps in the single user English only space. So.
I'll just add, I think this was a topic that was mentioned earlier today too, in thinking about where children are spending their time. There's a huge percentage for children during their waking hours. 50% of their time is spent at school. Younger children between 5 and 17, 5 and 18. And so we've already seen some companies that are providing school-based telehealth services. There was a huge uptick of that during the pandemic. And I think continued exploration is happening there because there's so much back and forth that happens with information sharing, like schools needing a child's vaccination records or getting a sports physical and connecting that back to the school. And so I think there's going to be, because of the places where children are spending a lot of time are, home and school, and then a small percentage of time in the formal healthcare setting, I think we're starting to see more innovative approaches with telehealth, with remote monitoring, that can connect across those places where children are spending a lot of their time.
So I think Lindsay alluded to earlier about the family being the ultimate unit for healthcare utilization. I think there's a tremendous opportunity for her in pediatrics. I think there's a role for technology in enhancing communication across generations and really helping children and families, particularly teenagers and families, engage in shared decision making. I see this as just a big gap in what happens now. We often sit there and talk to parents, but don't really down and talk to the level of the kids or of teenagers. And and that makes it really difficult to engage them in decision making.
Thank you. So pediatric innovation requires collaboration between a lot of different stakeholders. We've touched a little bit on collaboration with Medicaid, big tech, regulators. Help us understand who needs to be, what are the ongoing conversations and who needs to be at that table?
Well, we've talked about this a lot, and I think ultimately we need to bring a lot of different stakeholders to the table. You know, the tech companies that own or manage the device design in terms of what the operating system capabilities are for profiles in terms of caregivers and things like that. We need the regulators at the table, we need the payers at the table, and most importantly, we need families at the table to be part of this conversation with the clinicians and the developers to really make tools that are going to be successful and helpful for them.
Great. Okay. So I think we may have time just for, let's do kind of a one-liner take-home point, each of you, and then we'll open it up for Q&A if there are any. David?
Sure. So my one point is that I really believe that Medicaid is ready and interested, and it's time to invite them to the table.
Yeah, I mean, to keep it going with caregivers, I think really thinking about the family as the care delivery unit and building out different levels of profiles and allowing multiple users to have access to the health data in the way that they need to have access.
Thing that I'd love to reiterate to come back to making sure that patients and families are at the center of this conversation, not an afterthought. And I think predominantly at all stages of that life cycle, including design and intervention, and reaching beyond what as health systems we might be tempted to just reach out to our family advisory councils, but really going beyond the super users, so to speak, to out into the community and say, what does the tool look like in when it's not with the most highly engaged individuals?
And I will say the focus really, as you see here, the first bullet point, life course. We've talked about how the return on investment and thinking about pediatric healthcare requires thinking about long or lifespans, thinking about decades. And I think one of the exciting opportunities right now is for the first time, we actually have data on children who are now adults that have been captured across electronic health records because we've had electronic health record data for a few decades. We now have data on 30-year-olds who, starting all the way back from their birth. And so I think it presents a lot of new opportunities for us to better understand how investments early in childhood are actually leading to benefits across the lifespan. And so I think that's a really exciting area of exploration. I know one of the next panels is going to be talking about connecting and unlocking the value of pediatric EHR data. So I'm excited about that in terms of where we are today.
Thank you. It was nice to share this conversation with other people besides us in our weekly meetings. Yes, I'll open it up for questions.
And I just wanted to call out 2 QR codes on our slides up there. The first is to the Digital Medicine Society Pediatric Playbook that Sabrina mentioned at the beginning. We helped contribute to that along with a lot of other pediatric and research institutions across the world. And there's some really good information about specific focuses for children and some tools to help you better understand the pediatric landscape. And then there's a link to our little webpage, and at the bottom there's a contact form. We also have an email address. Feel free to fill that out or to send us a message if you're interested in participating in some of these discussions.
Yes.
Hi. Just a couple of points I wanted to mention. One is a question and the other is just a comment. The comment is regarding when you're designing, right from the design stage, you have to be thinking about the evidence package for the payers. I think that's an important point that oftentimes is an afterthought and quite late in the process. So, and my question is regarding, we haven't touched in this discussion about the role pharma can play in pediatric innovation. I'm sure folks in the room are aware that both the FDA and the EMEA requires a pediatric development plan for each drug that is in the pipeline when it's submitted. So my question to the panel here is, how can institutions like yours partner with farmers, because when we develop products for pediatric patients, there's a lot of digital technology that is used along with just understanding the safety and the efficacy of the drug product. How can institutions like yours partner with pharma as a collaborator as well? Thank you.
That's a great question. I don't know if anyone else wants to answer, but the digital medicine pediatric playbook, actually there was a lot of pharma representation at the table. And so there is, I think, robust information about that question. And how the interaction between the different stakeholders can actually facilitate the innovation. So I appreciate that question.
I mean, just to say the caregiver thing again, I mean, if a child is going through a research study, a drug validation study, a digital health tool validation study, their caregivers need to be part of that, and it needs to be designed so that they can easily contribute. And if you're dealing with someone that is in their adolescence and would be participating too, that they both have the role and the understanding of what they're going through.
So I think pharma and drug development for children, particularly for kids with relatively rare diseases, offers us an opportunity to say, how do we innovate and disseminate when there's a small market? What kind of support mechanisms do we need in place to make that work?
My question is about the caregiver situation. I think in the last 5 years, at least, I have, as one person, consulted for 2 startups that are in that space trying to build care coordination. And I've worked with one that has like a really robust suite of tools with several user types, even case managers. And so I'm thinking, if I first worked with a startup on this 5 years ago, how come that's still a big problem today? Is it that they can't reach you, or how did people like this find people like you who actually are concerned or see that need? Because I mean, I think there's a
Well, we need more people to spread that message. I think a lot of these tools are designed with an adult as a single user in mind. And, well, that's where a lot of the money is in, adult populations, people taking care of their own health and not really thinking about the kind of further ends of the spectrum where other people are caring for them. And I do think that it's part of the conversation. I can't say why that, I think some people are considering it, but I don't think that it's a broad consideration, because there's a little bit of a tunnel vision, we're making this tool for an adult to manage their cardiac care or whatever, and so who cares about everybody else?
And actually, the design thinking approach that is, the biodesign, the way that we sort of approach problem solving, finding the unmet need, and then analyzing the stakeholders, I actually think there's a need to expand it a bit because of the complexity of the family unit and the complexity of healthcare, where you have many different end users, and the customer is probably not any of those end users. And so, from my perspective, it's a problem that has yet to be solved in terms of creating a framework for addressing all of those needs.
Good afternoon. My name is Satish, and I am an entrepreneur building a digital health platform using Agentic AI. So my question is, recently a JAMA article came which mentioned that there are 500 residency positions which were got unfulfilled in pediatrics. In 2020.
Say that again. There are 500
unfilled residency positions.
yes.
In 2024. So clearly, rural area do not have much pediatrics, and now the positions are also getting unfulfilled. So what kind of digital interventions you people are already bringing or planning to bring at triage stage or at first time visit of a patient, of a child patient?
Well, our group specifically is not necessarily designing any tools, but more trying to come up with ideas and best practices and bringing people to the table to have conversations about this. But it is a need. We know that there's going to be a shortage of pediatric workforce. There's already a shortage, and there's a shortage particularly of pediatric subspecialists. And we saw that, telemedicine is one thing that helps bridge that access gap. But really, we have this opportunity to leverage digital health to connect patients and pediatric patients with clinicians that maybe aren't in their space. I think there's some regulatory issues that, the clinician has to be licensed in the state where the patient is getting the care. And so there's some of those things. But I do think it's an important problem that people should be thinking about. And I think, traditionally children are scary to a lot of people in that they, there's not a lot of investment in the space because people don't know what to do. And then I think there's also then traditionally been underfunding in pediatrics. And so then that leads to this thing where if people are going to a job for money, pediatrics is not the space where they're going to get that high paying job most of the time. And so really helping people understand the importance of this population in the health of people long term. But I don't know that we alone can solve it.
Yeah, I was just going to add, I think because there is this gap already of pediatric providers and it's getting worse, in particular with specialists, I think it is a place that people are going to turn to other sources of information. Right now with AI tools really proliferating, you hear a lot of stories of patients and people who don't actually have access to healthcare formally, turning to different AI tools. And overall, I think that's a positive thing in terms of the democratization of access to information, but we know that there's still a lot of issues with how general AI models work in terms of hallucination, and also a lot of concern more in that many of these generalized AI models, large language models, may not be trained and tuned to some of the specific needs of pediatric care. And so I think it's important in that AI conversation too, as that becomes more of a space where people are turning to information, particularly as they might not be able to see a pediatric subspecialist.
And I think to add on to what my colleagues were saying, there is the shortage problem, but there's also that distribution problem, right? So what we're seeing is there's some areas, I think as recent as 2024, when you look at the distribution of board-certified pediatricians, you see a very large concentration in the Northeast, and there's shortages in other several states. And so I think one of the things is that has been interesting models has been how can pediatricians talk to each other a little bit better and consult each other for sharing those stories. And there's a couple of different technological solutions in that space where a pediatric cardiologist in one area may be able to offer consult services to somebody halfway across the country that may be a family physician or maybe an adult ER doctor now faced with that problem of seeing that patient. And so part of that is also leveraging how we can talk to each other better too. And I think coming up with solutions there, I think is a huge opportunity.
And I would just add, time's up. Thank you very much.
Thank you. I think this could have gone on all day. We really appreciate it. Thank you all.